The University of Massachusetts Amherst acknowledges that it was founded and built on the unceded homelands of the Pocumtuck Nation on the land of the Norwottuck community. We begin with gratitude for nearby waters and lands. We recognize that these lands and waters as important relations with which we are all interconnected and depend on to sustain life and well-being. The Pocumtuck had connections with these lands for millennia. Over 400 years of colonization, when Pocumtuck peoples were displaced, many joined their Algonquian relatives to the east, south, west, and north. That includes Mashpee and Aquinnah-Wampanoag, Nipmuc, Narragansett, Mohegan, Pequot, Mohican communities, and Abenaki and other nations of the Wabanaki Confederacy. These Native peoples still maintain connections and relationships of care for these lands today. We also acknowledge that the University of Massachusetts Amherst is a land-grant university. As part of the Morrill Land Grant Act, portions of land from 82 Native nations west of the Mississippi were sold to provide the resources to found and build this university. As an active first step toward decolonization, we encourage you to learn more about the Native nations whose homelands UMass Amherst now resides on and the indigenous homelands on which you live and work. We also invite you to deepen your relationship to these living lands and waters.
Welcome to the University of Massachusetts for today's performance. Here, all are welcome and all belong. Please note the location of the exits nearest to your seat. In the event of an alarm, please remain calm and leave the building. The ushers will direct you. If you need special assistance during an emergency, please contact your usher. At this time, please silence all mobile devices out of considerations for those on stage and your fellow audience members. Thank you and enjoy the program.
Good morning. I feel like I should do a song and dance number here. Such a big auditorium. My name is Andrew Dreyfus, and I'm the chair of the Philip W. Johnson Massachusetts Health Forum. That's the first time I've said that name in public, so I want to spend 30 seconds telling you why we are now called the Philip W. Johnson Massachusetts Health Policy Forum. Phil was a friend of mine and a huge leader in healthcare in Massachusetts and in the nation. He sadly died suddenly at age 80 in April of this year. He was the chair of this Massachusetts Health Policy Forum, and his friends and his family and the sponsors of the forum got together and decided to name the forum after him. And I volunteered to take his place as the chair of the forum. Phil cared deeply about the issues we're going to talk about today, about the impact of federal spending, and in this case, unfortunately, federal cuts on low-income and other vulnerable populations. He loved this part of the state. He was a student at UMass Amherst. He graduated from this institution. He worked at Northampton State Hospital when he was an undergraduate, seeing firsthand the impact of state policies on, in that case, people with serious mental illness. And he loved to come out to Western Mass to visit programs. And I spent a lot of time, I worked for him for almost 8 years, coming out to programs and visiting clinics and community health centers and shelters and hospitals and other programs. So it's great to be here in Western Mass in kind of his homeland, excuse me, for the first Philip W. Johnson Health Policy Forum. So Massachusetts has long been a national leader in healthcare coverage and healthcare access and in healthcare affordability. We were the state, and I was involved in this process, that passed the first law in the country to guarantee, or close to guarantee, near universal access for everyone in the state. Our law became a model for the Affordable Care Act, which to this date has allowed tens of millions, that's tens of millions of people, to gain coverage who were previously uninsured. We also have a history in the state of bringing people together. You know, healthcare involves a lot of money, and there can be occasional conflicts, but we've been able to rise above those conflicts, and whether it's health plans like Blue Cross or hospital systems like Bay State, both of which I'll acknowledge in a moment, advocates, community health centers, human services organizations. We come together to solve problems. And this is a time we're going to need to do that again, because the system we've built up over 20 or 30 years is under threat from these cuts, and we're going to have to put aside some of our occasional differences to work together on behalf of our mutual patients, clients, family members. So this is why today's conversation is so important. This forum is going to give us an opportunity to review the data about what the cuts will mean, but to hear directly from those on the front lines, providers, policymakers, and community leaders, how those proposed cuts will affect people and programs in Western Mass. I want to thank our co-sponsors. First, the UMass Amherst School of Public Health and Health Sciences. We'll be hearing from the dean shortly. The Blue Cross Blue Shield of Massachusetts Foundation, which since its founding has been a leader in issues of access to care in the Commonwealth. In fact, today you're going to see the past, present, and future of the Blue Cross Foundation. Excuse me. The event is also co-sponsored by the Public Health Institute of Western Mass, and we thank Executive Director Jessica Collins for all her help with the event. I also want to thank, and it's on the screen, our sponsors, Blue Cross Blue Shield of Massachusetts, which is a sustaining funder of the forum, and Bay State Health, who helped fund some of our work focused on the western part of the state. There are a few other people I want to acknowledge who are at least scheduled to be here. Senator Joe Comerford, a longtime friend of the forum, who represents the Hampshire, Franklin, and Worcester District. State Representative Mindy Dome, representing the 3rd Hampshire District. We have staff here from Senator Warren and Senator Markey's office, and both of them have showed great leadership on this issue of the fighting for fair payment for Medicaid. There are a few board members from the forum here. Ian Lang of the Brookline Center for Community Mental Health, a huge leader nationally in mental health service. Connie Horgan, who co-directs the Schneider Institute at the Heller School of Brandeis. The Heller School is the home of the forum. And Audrey Shelto, who you will hear from in a minute, who is also on our board. So it's now my pleasure to introduce the dean, your dean, Maria Sigariz, who is both the dean and the professor at the University of Mass School of Public Health and Health Sciences. She is, most of you know her, a nationally recognized leader in nutrition and health policy, has served on several national academies and NIH advisory boards, at least the ones that still exist. And she's helped to shape dietary and maternal health guidelines that inform policy and practice across the country. Dean?
Thank you, Andrew, and good morning. It's my distinct honor to welcome you all to UMass and the Fine Arts Center. On behalf of our Chancellor, Javier Reyes, we are delighted to host and co-sponsor this event, which reflects our shared commitment to improving the lives of those in the Commonwealth and beyond. Today, we come together to address a pressing health issue that affects the well-being of thousands of our neighbors here in Massachusetts, the impact of recent Medicaid policy changes on health coverage and health outcomes. These impacts have profound implications for public health, social equity, and the very fabric of our communities. That is why today's forum is so crucial, to discuss, to understand, and mobilize effective responses to these challenges. Together, we will hear from experts, policymakers, and healthcare systems providers, and community advocates who are grappling with these challenges on the front lines. I thank each of you for your commitment to advancing health equity and for protecting access to care, for which the state of Massachusetts should be very proud of. Your participation is essential here as we seek to find solutions that will ensure that no one in Western Massachusetts is left without the health care they need and deserve. Let us engage in these important conversations with open minds and a shared dedication to the health and dignity of all. Thank you, and enjoy your morning.
Thank you, Dean. It's my pleasure to introduce Audrey Shelto, who is the president of the Blue Cross Blue Shield of Massachusetts Foundation. This is a little sad for me because this will be the last time I will be introducing Audrey, at least in my time as the head of the foundation, because she announced this year that she's stepping down after a remarkable 12 years leading the foundation and really 4 decades in service to the Commonwealth and serving people in healthcare and in mental health. There's probably not a law or a policy or a movement in Massachusetts in healthcare, low-income health, and mental health that Audrey Shelto has not contributed to. She's someone who leads with her kind of passion for making a difference for people who need help. She's led the foundation brilliantly through a challenging period of shifting public policy, shifting governments, both in Boston, in the State House, and in Washington. She's a close colleague and friend of mine, and we've been so lucky to have her, and for a few more months. And today she's going to moderate our panel. So, Audrey Shelto.
Good morning, everyone. It is great to see you. It's great to be out in this beautiful part of the state and very important part of the state. This is such a big room. It's a little harder to make eye contact with all of you, but I'm excited to see you here. We are here today to talk, as Andrew and the Dean spoke of, but a very sobering topic. And I'm reminded of a conversation I had with a friend of mine very recently, a professional colleague, and she was wearing this really nice outfit, which I am not suggesting I am. But I said to her, "You look great." And she said, "Well, I decided to dress for how I want to feel instead of how I really feel." And my tone in this moderating today is going to be that this is a tough time, a really tough time, almost unprecedented in terms of the challenges we are facing. But again, as Andrew said, if anybody can withstand these devastating cuts and policy changes and try to make the best of them, I know we in Massachusetts can. So I'm going to approach today with that kind of attitude and that kind of tone, which is we can work together and we can try to mitigate the damage that can be done by all of these cuts. So we have an exciting day for you, I think. A great presentation and then some great speakers. I'll tell you a little bit about how the day's going to go. First, we're going to have a presentation from Caitlin Kenny Walsh, who is not only a dear friend of mine, but also the Vice President for Policy and Research at the Blue Cross Blue Shield of Massachusetts Foundation. And in the spirit of Andrew's introduction to me, I should also introduce her as the future President and CEO of the Foundation. Caitlin will be starting January 1st. So then Caitlin will do her presentation. If you have questions, comments, anything you want to say about or questions about her presentation, I guess there might be cards around there already. If not, there'll be people walking around with cards. You can put your question down on the card, and then it'll be brought up to me. Excuse me, and when Caitlin's done, I will ask her your questions. So we'll go through that, and then after we've had full discussion with your questions, we'll take a break, and then we have a very fantastic panel that will really bring the Western Mass perspective to both the challenges that we're facing and also the potential solutions to this problem. So far, I would say most of the data we have are statewide. And I know for those of you in this part of the state and many other parts of the state, you're anxious to get it broken down more regionally. And that will come, but we don't have the data yet. So we thought in putting this forum together with the Health Policy Forum, what better than to have some leaders from this part of the state talk about what they see coming and what they see as potential strategies to deal with these problems. So that's how we'll handle the panel, and then you can again, at that point, there'll be mics around the room, and you can just stand up and let me know that you want to ask a question, and I'll facilitate that part of the process. Okay, so with that, I think you have everybody's bios in your materials, so I am not going to read through lengthy bios. I think I already sort of blew my headline in terms of Caitlin, but Caitlin is, as I said, she's the Vice President for Policy and Research at the Foundation, and I should also note, before she joined us at the Foundation, she worked for many, many years as a lead policy person at the Health Connector, so really brings a lot of experience on these issues prior to her experience at the Foundation as well. And with that, I am going to turn it over to Caitlin.
So it's the moment of truth. Do the slides advance? They do. That's a great start. So I am just going to make sure that I have us set up so I don't go over my time. My name is Caitlin Kenny Walsh. As Audrey mentioned, it's a pleasure to be here with all of you today. Thank you for the opportunity to speak with you about this law and the impacts in Massachusetts. As Audrey mentioned, my presentation will mostly focus on the system-wide and statewide impacts of this law, but I know that the panel will really get to the heart of how this will play out in Western Massachusetts. I will say that I typically prefer to be the bearer of good news. Given what Michael Doonan asked me to speak about today, that's not exactly my role. But I promise that I'll try to end on some uplifting notes. So let me orient you today to what I will cover. I'm briefly going to give you an introduction to the Foundation, for those of you who may not know us. Then, to provide some key context and background, I'll orient you to the key public coverage programs in Massachusetts. After that sort of setup to contextualize us, the second half of my presentation will first focus on, what are the key provisions, healthcare related, in the One Big Beautiful Bill Act. And just to simplify things, you'll hear me use the term OB3 when I'm referring to that law. In part, that's because we need more acronyms in healthcare policy. We don't have enough yet. And then after sort of a setup of the description of some of the key federal policy and financing changes, I'll talk about the impacts of those in Massachusetts. So briefly on the Foundation, our mission is to ensure equitable access to health care for all residents in the Commonwealth who are economically, racially, or culturally marginalized. We really advance this mission in using 3 key strategies and in 3 particular focus areas. Our focus areas are in care and coverage, in behavioral health care, and in structural racism and racial inequities in health. And the way we advance our mission is really through our policy and research work, which aims to elevate issues for the public dialogue. And we do that both by educational resources that provide information to people on complicated or complex healthcare programs, which are most of our programs, and also through analytic pieces that look at key issues of the day and offer potential solutions for how we might improve access or improve other aspects of our mission, improve equitable care. Another strategy we use is our grant-making work. We make strategic investments that both provide support to advocacy organizations who are doing work in line with our mission, as well as providing funding for opportunities to test innovative models of improving access to care. And finally, our convening work. We do convenings and events in an effort to share policy and research findings, to disseminate best practices, and also to learn from the community about key issues that we as a foundation should be focusing on, how we can involve the community in an effort to advance our mission further. Okay, so I'm going to start by reviewing 2 of the public coverage programs in Massachusetts that are really the cornerstone of our near universal health insurance coverage landscape. I'm going to begin by talking about Mass Health. Mass Health refers to, in Massachusetts, both the Children's Health Insurance Program and our Medicaid program. The Mass Health program covers roughly 2 million people. That's more than 1 in 4 residents. It includes low-income children, seniors, and people with disabilities. And I'm not going to go through all the statistics on this slide, but I just want you to pause for a minute and think about, we're talking about nearly 1 in 4 Massachusetts residents. We're talking about, 1 in 2 children. So all of us know somebody who has utilized Mass Health, who is a Mass Health member. Some of us may be on Mass Health. The scope of this program is something I want to make sure we're really mindful of as we begin our discussions today. To qualify for Mass Health, it is primarily income driven. Most adults under age 65 with income below 133% of the federal poverty level, which is roughly $21,000 annually in 2025, are eligible for the program. Individuals with income above this limit may also be eligible on the condition of a disability, a pregnancy, or for many kids. Again, so for those populations, the income threshold is higher. I want to orient you a little bit to this sort of slide, which demonstrates enrollment in Mass Health by geography. This slide shows you the percentage enrollment in Massachusetts by county. The darker the purple shading is, the higher the enrollment rate is in that county in Mass Health. What you'll see here are a few things. First, people across Massachusetts are enrolled in Mass Health. Second, if I bring you specifically to looking at sort of the Western Mass portion of the state, there is stark variation in terms of the enrollment in Mass Health. This is true in Western Mass and across the state, but this is largely driven by income and other demographic factors. But if you look in Western Mass at the counties here, you will see the enrollment in Mass Health ranges from a low of 18% of residents in Hampshire County to a high, did I say it correct? Hampshire. I'm Massachusetts native and I still don't get it right, but I do know Worcester and how to pronounce some of those terms. To a high of nearly 42% in Hampden County. So again, you're talking about counties in this region where a significant number of people, and of course providers and provider institutions, will be impacted by these changes. I want to turn briefly for setup to Mass Health financing and the way this program works. Just for starters, recognizing we have a broad audience of folks who bring different experience and expertise to these conversations, Mass Health is a program that is funded jointly by the state and the federal government. The federal share of cost for the Mass Health program is established by a formula, and that formula is often referred to as the match rate. Most of Medicaid expenditures are matched at roughly 50%, so that for every dollar that we spend in Massachusetts, the federal government chips in 50 cents. There are some programs and populations where that match rate or that formula differs. One good example of that is coverage for what we call in Massachusetts and across the country as the expansion population. So people who became newly eligible for Medicaid as a result of the Affordable Care Act. For that population in particular, the federal share of costs is 90%. So the federal government picks up a significant majority of the share of costs for that particular population. And what you can also see on this slide is that this shared financing means that Mass Health brings in a huge source of federal revenue to the state of Massachusetts, $12.3 billion, and a whopping 86% of the total federal revenue that comes to Massachusetts. This program is critical. I want to orient you. I know we're focusing specifically on Medicaid, but the truth is, when people lose coverage, which is what is going to happen, it's not really going to matter if they came from losing coverage through Mass Health or through the Health Connector. And since there are significant coverage losses driven by eligibility changes in marketplaces, I think it's important to orient you to this as well. So the Health Connector is Massachusetts' Affordable Care Act compliant exchange or marketplace. It offers health and dental coverage for individuals and families and small businesses. We're going to focus today on the coverage that it offers to individuals and families. And I'm going to group it into sort of 3 types of coverage options. The first is unsubsidized commercial insurance. So people who don't have a subsidy, they're paying on their own, they go to the marketplace, and they're really using it as a tool to help them compare different plans. The second option is APTC-only coverage. Again, another acronym because that helps make things really easy for all of us. That's Advanced Premium Tax Credit Only coverage. So people who have a subsidy through the federal government to purchase their health insurance coverage. This is largely people with income above 500% of the federal poverty level in Massachusetts. And finally, where you see the bolus of enrollment through the Health Connector, which is in the Connector Care program. This program provides affordable coverage to individuals with income up to 500% of the federal poverty level who meet those income requirements and who are not eligible for Mass Health, Medicare, or other affordable coverage. So taken together, nearly 400,000 people get enrolled in health insurance coverage through the Health Connector. I won't get into the details here, but the coverage, the subsidy, the tax credit that really is sort of the undermining financing mechanism for these that enables people to get more affordable premiums and co-pays, that's really at the crux of the federal debate right now for the government shutdown. So I'm going to now turn the second half of my presentation to some of the key marketplace and Medicaid provisions in OB3. You now have sort of some context in the public coverage landscape in Massachusetts, and I'd now like to turn to, what are some of the key healthcare-related provisions in this law? So this law passed in July of this year, and it is a sweeping, massive law. I won't be covering all of the many pieces of this law. The law extended the 2017 tax credits, and it also increased spending on border security, energy, and defense. And to finance those expenditures, we needed to find, through this law, savings. The savings were found in large ways through our Medicaid program. And I will cover some of the key provisions of this law that result in significant reductions in federal financing and eligibility for these programs. I will note that most of the eligibility cuts for coverage trickle in over the next 2 to 3 years, but the full impacts of this law will not be felt until about 2034. So as we think about the types of cuts or changes that this bill introduces, we've been thinking about them in really 3 primary buckets. There are cuts to Medicaid eligibility, there are cuts to Medicaid financing, and there are marketplace cuts. I'm going to briefly talk through each of those before shifting to the impacts. So the first section of cuts are specific to Medicaid eligibility. The OB3 imposes new eligibility requirements on the expansion population. These new requirements primarily apply to people who are 65 and under, who do not qualify for Medicaid on the basis of a disability or a pregnancy, and who are income eligible under 133% of the federal poverty level. The work requirements are such that for applicable populations, and I will note that the state is still awaiting federal guidance that will provide the details of who specifically this applies to. But the law requires that the people to whom this applies must be in school, getting an education, working, or participating in community engagement activities for 80 hours a month. What we know in Massachusetts is that over 3/4 of non-elderly Mass Health members are already in working families, and those who aren't working are often in school or are taking care of children or family members with disabilities. Nonetheless, some people will lose coverage because they don't comply with these new requirements. Many others will lose coverage because of the added paperwork or administrative barriers associated with meeting or proving this requirement. They don't receive or understand the notices that they receive, or they don't have the right paperwork to prove their work or community service, community engagement activities. And just to be clear, about what we do know about these types of requirements. Arkansas did implement work requirements in their Medicaid program, and their experience suggested that the imposition of work requirements did not change employment. What it did do is increase the number of people who lost their Medicaid coverage and increased the uninsurance rate in the state. 6-month redeterminations are another change, shifting from redetermining people every 12 months to every 6 months. This is a cut that will just make it harder for people to stay enrolled in coverage. We know that people often lose coverage not because they're not eligible, but because of the administrative barriers and the red tape of proving they're eligible. It's a lot of work. So more frequent redetermination will just create additional hurdles to people keeping their coverage. The next bucket of Medicaid eligibility cuts are with respect to changes in immigrant coverage restrictions. So this provision scales back the categories of legally present immigrants that can now qualify for Medicaid. What this means is that many groups of legally residing immigrants who used to be eligible for Medicaid, so that list on the right side of the slide, which introduces refugees and asylees, they will no longer be eligible for Medicaid. And state estimates suggest there's roughly 2,500 people who will lose coverage as a result of this change. And I just want to be clear, these are lawfully present people. There's a lot of noise in the dialogue, but these are people who have followed the rules, they've submitted their paperwork, they are currently eligible, and this is a shift in terms of eligibility criteria for particular immigration statuses that will lose their coverage. The next set of cuts here are the financing cuts, and there are a number of financing cuts. I've chosen to highlight 2 particular cuts that are significant drivers in terms of the federal revenue that the state will receive in order to run its Medicaid program. As I mentioned earlier, Medicaid is financed by the state and the federal government, with states paying roughly half the cost of the program. And so again, 2 significant drivers of these changes are changes that you see on the slide behind me, the imposition of changes to provider taxes and to state-directed payments. Provider taxes are an established tool used by nearly every state in the country to finance their share of the Medicaid program. They provide a key source of funding that states can use to generate revenue to fund their share of the Medicaid program. They are assessments on entities like hospitals, nursing homes, ambulances, MCOs, that states generate to pull down their share of financing for the program. That money is then matched by the federal government, and then it is reinvested into the healthcare delivery system. In Massachusetts, in state fiscal year 2025, these assessments will generate roughly $2.3 billion in revenue. The law places new restrictions on these provider taxes. It prohibits new taxes, and it requires existing tax rates to be phased down over time. As is the case with many other provisions that I'm talking about today, the devil is in the details here with respect to how these will play out for each of our specific taxes. We do know that our MCO tax is not in compliance with this law and will need to be significantly restructured or phased out over time. But limits on provider taxes will reduce the federal reimbursement that Massachusetts generates. That means Massachusetts, like many other states, will have to figure out what changes they make to their Medicaid program to account for that lost revenue, what cuts it makes, or if there's an opportunity to generate money from the general fund to offset some of those losses. State-directed payments, another key source of changes in federal financing, are something that have been established over the course of the last 10 years that allow Medicaid MCOs to enhance rates for hospitals and providers. They're often tied to system-wide value-based payment reforms or quality improvement efforts. And as with other Medicaid spending, states and the federal government share in the cost of state-directed payments. These payments help close the gap between low Medicaid rates and the actual cost of care and they're seen as really critical for safety net providers and rural hospitals and places that serve a disproportionate share of Medicaid members. Massachusetts provides state-directed payments in fiscal year 25 of just over $2 billion. OB3 places new restrictions on state-directed payments. They cap state-directed payments in expansion states, which we are, at 100% of Medicare rates relative to the current, which is the average of a commercial rate. Massachusetts does make a number of state-directed payments that exceed the Medicare rate, and these include payments for behavioral health services and for hospital services. So again, rates that will need to be brought down in time. In recent modeling that Manat Health has done, not including MCO tax impacts, new restrictions from these two provisions alone, so from state-directed payments and provider taxes, account for 33% of the expected cuts in total Medicaid expenditure rejections. That same analysis suggested that by federal fiscal year 2034, Massachusetts will have almost $1.6 billion less to spend on Medicaid due to hospital taxes and state-directed payment changes. I told you I wasn't bringing good news. So marketplace eligibility changes. I've talked through some of the major changes with respect to Medicaid eligibility cuts and Medicaid financing. There are also some critical changes with respect to coverage through the marketplace, again tied to changes in eligibility based upon one's immigration status. The first set of changes take effect as of January of the coming year. These categorically exempt all lawfully present immigrants from getting their coverage for subsidized coverage through the Health Connector. These are individuals under 100% of the federal poverty level, so we're talking about roughly $16,000 a year, and they will no longer be eligible for current tax credits that enable them to access more affordable health insurance. They are able to buy full-cost health insurance from the exchange, but given the income parameters I just shared, that's highly unlikely. Right now, enrollment among this income cohort is roughly 36,000 people. So again, they will lose their subsidy, enabling them to get affordable health insurance through the Health Connector. In January 1 of 2027, additional changes in eligibility based on immigration status set in. They're not exactly the same immigration restrictions as those that apply under 100, but a subset of immigrants, again, lawfully present immigrants, will lose their coverage in January 1, 2027. The Health Connector currently estimates that between 25 and 30,000 people will lose their coverage as a result of this provision. So taken together, that's close to 60 or 70,000 people losing their coverage as a result of these changes. The other piece I alluded to, the enhanced premium tax credits are set to expire in December of 2025. For anyone counting, that's 2 months away. And these enhanced tax credits removed the previous income eligibility ceiling for premium tax credits. So if they expire for anyone with income above 400% of the federal poverty level, there are no subsidies available to them anymore. That's particularly important in places where health insurance costs are expensive. Ding, 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 that's Massachusetts. And also really important for older people for whom health insurance premiums tend to be higher. So that's one significant loss. In Massachusetts, nearly 27,000 current Health Connector enrollees with income above 400% of the federal poverty level may use these tax credits. And for people under that income cohort, they may still be eligible for subsidies, but at significantly higher, they may be eligible for subsidies, but their costs may be significantly higher. And if the federal government fails to extend these, Massachusetts will lose roughly $425 million in federal tax credit support. Okay, so now, having covered some of what the key provisions are, I'm going to turn to speak about what some of the potential impacts are in Massachusetts. Again, I said I typically like to end on a high note, so I will get there, but I promise you it's going to take a little bit before I get there because the impacts are dire. I will note, as I alluded to, that there are a lot of unknowns with respect to how these healthcare-related provisions will be implemented. In part, that's because we're still waiting on federal guidance to govern the specifics of them. What we do know is that the health-related provisions in these laws are far-reaching, far-ranging, with significant impacts. They'll have impacts on enrollment, on our expenditures, and specifically for our subsidized coverage programs. But one key theme I would like you to take away is that the impacts don't end there. These impacts will ripple through our entire healthcare system. And so this really is a moment when we all need to be in this together. So I'm first going to talk about some of the coverage impacts. I set up what some of the key changes are with respect to changes in eligibility for subsidized coverage programs. There are a lot of different estimates that are floating out there. We've aligned our estimates for consistency with those put out by the state, which suggest roughly 300,000 people will lose coverage. This includes 200 people who will lose their Medicaid coverage and up to 100,000 people who currently have coverage through the Health Connector or the state's marketplace who will lose their coverage. While we primarily rely on state estimates, we did look, some of the key drivers of these changes, as we mentioned, are the work requirements and the 6-month redetermination provision. The foundation did an analysis with the Urban Institute to really understand what the impacts of these two new requirements would be on coverage. The state estimated roughly 175,000 people would lose coverage as a result of these provisions, and our estimate was in that same order of magnitude. We estimated that roughly 141 to 200,000 people would lose coverage as a result of these provisions. And we went a step further and said, of those losing coverage, we learned that roughly 90%, or about 110 to 180,000 people, would not only lose their coverage, but become uninsured. Just for context and as a point of reference, the most recent state Massachusetts Health Insurance Survey was conducted in 2023. The Center for Health Information and Analysis does that study. At that point in time, and a lot has changed since then, but at that point in time, there were roughly 120,000 people uninsured in Massachusetts. So these numbers suggest, you could have up to a doubling of the uninsured rate in Massachusetts. On the Health Connector side, the key changes that I spoke to in terms of changes in immigrant eligibility coverage will also have huge implications here. Again, we spoke to the changes that result from changes by income and also pending the enhanced premium tax credits, what that will mean for people. These numbers could go up depending on choices made with respect to how the state chooses to handle them. They also may go down. We do have a track record here in Massachusetts. I think about the Medicaid redetermination campaign that we went through after the maintenance of effort requirements tied to the public health emergency and COVID. We thought a lot of people would lose coverage, but through partnership, community outreach, extensive work by the state and advocates and community partners, we were able to retain our coverage rates. So I do think it's important to note these are estimates. They could go up, they could go down, but they give us a good gauge for how to think about the work ahead. I want to talk now about delivery system and broader access impacts of these changes. State officials estimate that Massachusetts will lose $3.5 billion in federal healthcare revenue per year when this law is fully phased in. This will be a major challenge for the state's Medicaid program, which will be forced to make really difficult changes around, potentially what services get covered, changes to benefit packages, who gets covered, limits and enrollment in some optional programs, or cuts to payments and providers, or some combination of all of these. This also puts the Massachusetts budget in a very difficult place, given that federal revenues supply a little under a quarter of the funding for the state budget. sorry, I messed up my slides here. Given that federal revenues account for just under a quarter of the state budget, and that the Mass Health revenue is about 86% of that. And this is critical in terms of supporting the state's broader economy. So while we've talked a lot about the impacts these cuts will have on subsidized coverage programs, there's no doubt that these cuts will have broader impacts on the entire state, the state budget process, and all the programs that depend on state financing to continue to move forward. And I'll just note that I'm focusing very specifically on healthcare programs, but many of you know, I mean, even this morning, there are many other programs that are taking a hit. Think about SNAP benefits, think about education benefits. There are many other things at play here that will be competing for significantly fewer resources. In terms of the broader delivery system, so we talked about a lot of people losing their Medicaid coverage. It turns out when people lose their health insurance coverage, they don't stop needing medical care. They don't just stay healthy. And so these people will continue to need to get health care. Many will show up at hospitals, potentially with more acute conditions or being sicker. Some people will present at emergency departments, maybe for conditions that could have been treated elsewhere, but where they don't have access to care. And so we know that this will be happening, this presentation of people without health insurance coverage, which is often referred to as uncompensated care, at a time when our systems are already strained. In Massachusetts, Medicaid represents about 20% of inpatient hospital revenue. So Medicaid is a really important source of revenue for hospitals. Not only will patient care be compromised as a result of some of these changes, but it's also important to note, and I think you'll talk about this more in your panel today, hospitals are critical employers. They are critical employers in the community that they serve, and they're also therefore a critical part of the broader state economy. So the ripple effects there will be large. Increases in these uncompensated care costs, again, will ripple through both the hospitals, people seeking care there, and broader communities to the extent people are employed by their hospitals. Manat Health projects that hospitals would see major reductions in Medicaid payments, losing 18% of their Medicaid funding, almost $16 billion in losses over the 10-year period from federal fiscal year 2025 through federal fiscal year 2034. Other providers will also feel the impacts of these cuts. For community health centers, Medicaid represents roughly 50% of their revenue. Community health centers are a crucial source of care for more than 1 million people in Massachusetts, and they will face decreased revenue at a time when they are already in a fragile space. We don't have system-wide impacts for community health centers yet, but we've seen several articles in the paper indicating that community health centers are already facing the challenge of layoffs. One community health center in the Outer Cape indicated that over the next few years, they expect to experience a 30 to 40% decline in their revenues. So these changes that I've talked about may be largely driven by the federal changes relative to eligibility for publicly subsidized programs and the financing for publicly subsidized programs. But I really want to make clear that in a time of constrained revenue and constrained money to pay your staff, to pay the real estate costs for your buildings, this will mean really tough choices. Places may have to lay off workers, including clinicians. People may have to choose between paying the real estate to keep a facility open, which could ultimately mean longer wait times for services for all of us and longer drives to access your care. I just want to reiterate, this is not a Medicaid problem. This is an every health insurance coverage, healthcare delivery system problem. So before I turn to questions, I promised some optimism. And here's my optimism, which I think really sits well with some of the comments Audrey offered and Andrew offered. You know, next April, we will celebrate the 20th anniversary of Chapter 58 in Massachusetts. For those of you not familiar with it, that was the state's landmark near universal health insurance law. It really set the model for the Affordable Care Act. And I think many of us who were committed to standing up that law and implementing that law just don't have the stomach to see it unravel. There is so much passion for the work that we did and so much commitment among people dedicated to the goal of near universal coverage that will be powerful, that will have a role here. I will also say that the people working in this space, in the healthcare reform space, many of the people who have been doing it for decades. They might have worn different hats and traded seats, but they've been doing it for a long time. And that's really enabled some strong and critical, trusted relationships to work together through incredibly hard times. Andrew spoke to them earlier. I think we're there. And I trust that some of those long-standing trusted relationships will make a difference in finding solutions. I often say that you know you've done a good job finding solutions in difficult times when nobody's happy, but everybody can live with it. Two quick things I'll also share. I think this concept of shared responsibility that characterized the reform in April of 2006 still persists. People here are still willing to take some responsibilities. Employers, hospitals, health plans, we're all willing to do something. And I think that concept of shared responsibility matters. And finally, we live in Massachusetts. We endure insanely hot summers and bitterly cold winters. People here are tough, and they are gritty, and they are willing to put that toughness and that grittiness towards challenges like what we're facing now. So thank you.
So the people that are going to lose coverage, could lose coverage if the tax credits aren't extended as of January 1st, 26. Is that because of OB3 or state dollar cuts?
So we know, so the people who will lose tax credits, the enhanced premium tax credits, which are part of the discussion right now under the federal government shutdown, people above 400% of the federal poverty level who are getting those tax credits, if those are not extended, those people will lose coverage as a result of that discussion, which is not specifically part of OB3. People who will lose coverage as of January 1, 2026 due to their immigration status, that is a specific provision of OB3.
Great, thanks. Not great, but thank you. Gotta watch, see, you gotta really watch it here. So this, the whole churn issue and all the administrative burdens and the increased hassle in keeping coverage. A couple questions on that. When you think about the eligibility and enforcements, are there ways that providers and other community members can help with that? Are there things that they can do to help people understand what's coming, what they need to do in order to keep their coverage?
Yeah, I think that's exactly right. I referenced briefly the significant work that the state did as part of the redetermination process following the COVID-19 extension of coverage and the need to redetermine people eligible as part of that process. That had the potential to be insanely confusing. It's a lot to pull together all your information. The documentation criteria are a lot of paperwork, a lot of questions. And I think for any of us in the middle of your busy life, that's just a lot to do. Not to mention you get so many emails, so many text messages, so much mail. It's like, what do I really need to respond to and what do I don't? And this is something you must respond to. And so I think about part of what made that effort so successful, and I promise I'll get back to the question, is exactly this. It's thinking about a multi-pronged strategy across all of the stakeholders. So it's thinking about the providers who work with people who are potentially subject to these requirements and could lose their coverage. It's thinking about the health plans who serve them. It's thinking about our community-based organizations that interact with people who may be subject to these requirements every single day. And frankly, many of these people, particularly again, Medicaid and the coverage cuts we're about to see through the exchange are hitting some of the most poor people in the Commonwealth. So many of them are just fighting to make sure they have food on the table and that their rent is paid. So the added work of doing this is a lot. And so making sure we're using all those trusted partners to say, this is really important. All those pings you're getting, this is actually one of the ones you need to respond to. And helping people to figure out how to do that, I think, is a critical strategy. Having a cohesive message and having lots of different stakeholders and players play a role.
Thanks. I think you alluded to this, but just to make it very concrete, without these subsidies, when the premiums go up for some of the connector products, do we expect people to drop insurance as a result of that?
So we are well positioned in Massachusetts in that we do have state subsidies on the existing premium tax credits. So the state is well positioned, but maintaining the sort of current share in terms of enrollee share and state share will mean, greater state costs. If we aren't able to do that, we know that insurance is really expensive for people. Even with subsidies, it's still expensive for people. We also know that the cost of milk and gas and all of these other things are going up. So people have significantly fewer resources. And so we do believe without continuation of subsidies and without continuation of strong subsidies, people will lose coverage and people will become uninsured.
And I think the next few questions have to do with sort of wondering about the breadth of impacts of these cuts in terms of the actual service delivery. So questions about what's going to happen, and what are the ideas? Do we have any plans to address the needs of older individuals, people with disabilities, people using personal care attendants, those with disabilities who use the PCA program, interpreters and other language services? So all the things that we all kind of, we have in our system today that are primarily funded by Medicaid.
Yeah, it's a great question. And I think the answer is we will be doing we will have significantly fewer resources available. And so these changes in federal finance and monies for the program will mean the leaders of our Medicaid program, our state policymakers, will really have to make some tough choices about what services to keep, what services may go, and many of those services may be programs that kind of come under the chopping block in terms of ways to find savings for the programs.
Yes. Okay, two last questions. One, I know the answer is yes, the way the question's phrased. Have you been monitoring the new interpretation of the Personal Responsibility and Work Opportunity Reconciliation Act, which would prevent immigrants from accessing services provided certain immigrants from accessing services provided by community health centers or other safety net providers, even if they're not funded by federal dollars? Which I think would be another whole conference.
Yeah, so we have been monitoring this. We've been working really closely with our colleagues at the Massachusetts League of Community Health Centers. And I would just say, this is, I said I was focusing my comments on a few specific provisions. This is another related provision that will have significant impacts on our healthcare delivery system. And this hits from all sides. This hits consumers who need care and will continue to show up. And it also hits provider institutions who are trying to fulfill their mission of providing care to people. So we've been following this. I won't say that we have any comments in terms of our legal interpretation of the impacts that this will have.
And last question or comment, which I think is really important, as they all have been, is that given that many residents and provider systems across the country and in red states are really going to suffer as well as a result of these cuts, in some cases even more so than Massachusetts. What are your thoughts about, or what are awareness about what Massachusetts policy leaders are doing to sort of go across states, really find allies in other states to try to react and try to get changes to some of these provisions.
Yeah, so I would say we're lucky in Massachusetts. Our Massachusetts Medicaid leaders, our state officials, they're committed to doing the best that they can to mitigate the harms of these laws. I think they are constant. We love to think in Massachusetts, and we are, but we love to think we're a leader and that we're always doing things at the cutting edge and in the best way. And I think we've learned, and we're lucky enough to have leaders who recognize you always need to do your due diligence on that, and you always need to talk to others in other states. And I think our state leaders are continuing to do that and to learn from other states, particularly as we think about implementation of these work requirements, what works, what doesn't. And also, mind you, this is happening at a time where we have to meet an implementation timeline, but we don't necessarily have the federal guidance we need to make that operational timeline feasible. So our teams are doing all the work that we can to do this, and I think there's also a strong need when you think about the impacts of this over time and across the nation to document this particular change had this impact, because these timelines were sequenced intentionally so that much of the harm happens after key election cycles.
Great. Well, thank you. I got to break the habit of saying great in forums like this. Thank you. Okay, I'll just say thank you. Thank you all for your questions. Thank you for your attention. So much of the information we have so far is statewide, and thank you very much to one of our panelists in particular for helping to make that information available. So we thought it'd be great for all of you and those of us at the foundation, frankly, to hear from folks who are in leadership positions out here in Western Mass about, what are they thinking about all this? How are they thinking about the impacts? It's early, it's hard. What are they beginning to think about in terms of how to deal with all this? So that's our intent with this panel, and I'm confident it's going to be great. So just brief introductions to start, and then I will do a series of questions with the folks just to get the ball rolling. But then any of you, I think there's going to be people with roving mics, so just raise your hand if you have a question or comment. It can be to anyone on the panel. It can be to someone specific on the panel, however your question applies. So first, to my immediate left is Undersecretary Mike Levine, who is the head of the Medicaid program, which is called Mass Health in Massachusetts. So we are we're honored to have everybody here. But I really appreciate Mike coming out from Boston with all that he has on his plate, and to talk about and hear from you about the specific impacts in Western Mass. The next person we have is Tanya Barber. Tanya's been working at the Caring Health Center in Springfield for many years and is the president and CEO there. And the Caring Health Center is the only federally qualified health center in Springfield. And as you heard earlier, in Hampden County, we've got a really high percentage of people who receive their insurance through the Mass Health Program. And next we have Dean Sampe, who is the Chief Strategy and Administrative Officer for Bay State. Bay State is, I think you know, one of the largest employers out here, serving over 1.8 million patients. So really, really major provider, employer, community engagement organization. So he'll talk about his perspective. And then last, but certainly not least, we have Alana. Oh, I just have to find the right page. Okay, Alana Steinhauer, who I've known for many years since I first started at the foundation, who is the executive director of the Volunteers in Medicine program here in the Berkshires. And I think it'll be really interesting for all of you to learn more about that program, as I did many years ago, and think about, what role are organizations like that going to play going forward. So we've got a great panel, as I said, and we'll dive right in. Mike, before we get into sort of specific questions to Western Mass, was there anything in Caitlin's presentation that you want to sort of, from your perspective, want to highlight or sort of pull up for more attention?
Sure. Well, good morning, and thank you to Audrey and the Foundation for having me. It's actually a particular pleasure to have someone else go through all of the doom and gloom statistics. Typically, when I'm invited to these things, that is my primary responsibility. So to get to follow Caitlin's excellent presentation is a welcome change. No, I thought Caitlin covered the bases really well. And I guess, to the point that one of the questions asked towards the end of the prior session, how are we talking to and learning from and partnering with other states? There's some comfort in knowing that every state is going through some version of what we are about to experience. And I would actually highlight 3 challenges that we are facing kind of all at once, right on top of each other. The first is what Caitlin really focused on, which is OB3. You can think of as there's like a giant sucking sound of money leaving the Commonwealth as federal dollars flow back to DC in the form of less support for a Medicaid program. It's really challenging. We'll talk more in the coming hour about how we're going to address it, and I think we'll do a great job here in Massachusetts of landing the plane as softly as we can. That's challenge 1. Challenge 2 is that right now, healthcare cost and utilization is growing at a rate we have not seen in a very, very long time. Obamacare premiums across the country are up about 18%. Here in Massachusetts, commercial premiums are up about 12% next year. And the trends that are driving healthcare spending up for every employer, for everyone who pays premiums, for every Medicare beneficiary, are the same trends that are unfortunately driving up Medicaid spending in Massachusetts. So we are seeing record growth in drug costs and utilization. We are seeing significant increases in the utilization of long-term supports and services and behavioral health and other critical services. But the problem is when a Medicaid program grows at, let's say, 12% per year in spend, and the budget that supports our spending grows at 2% per year, that's a 10-point gap between money we need and money we have. And when you apply a 10 percentage point gap to a $22 billion program, which is Medicaid's annual budget, you just kind of blew a $2.2 billion hole in the budget. And that is a problem that is in front of us right now. Again, we are seeing healthcare cost growth at a rate that far exceeds the resources available to the state, to employers who are trying to pay premiums, to families who are trying to pay out of pocket. And it is going to drive a lot of innovation and a lot of hard decisions around how to deliver great care at lower cost. And I know Tanya and Dean spend a lot of their days thinking about that in partnership with us. So that's challenge number 2, which I think is going to really inform kind of how we navigate some of the federal changes as well. The last piece I would just say is that, demographically, Massachusetts is changing and specifically aging. And if you think about a Medicaid program, we are the primary payer of long-term services and supports in the Commonwealth. Whether you are living in the community receiving home care services of various types, whether you are going to a day program, or whether you are living in a nursing home, Mass Health is probably paying for those services. And as we look ahead to the next 5 to 10 years with significantly increased number of individuals, particularly over the age of 85, which is a wonderful thing because we're living longer, it does also mean, okay, the state needs to get creative and figure out how to continue to be able to support those services. Now, normally, channeling Caitlin's comments about grittiness and creativity and trusted relationships, I would say, we can handle one of those problems. I think really what we're trying to sort out now with our partners in the community, healthcare providers, our partners in the legislature is how do we tackle all 3 of these at once? We have a playbook for some of the eligibility changes that I'm sure we'll talk about more, and again, it's kind of a question of minimizing the damage or landing that plane as softly as possible. Those other challenges around reining in cost growth, making difficult decisions to manage budget pressures, and making sure that we're going to be able to sustain the program, particularly for older adults who are going to really depend on Mass Health in the years ahead, are kind of that's what's keeping me up right now. So I thought it was a great summary, and I would just layer on those additional pieces that kind of, I think, bring into focus the challenge that our Medicaid program and frankly every other Medicaid program in the country is facing.
Thank you, Mike. That's really helpful additional framing. And I am sure you're not sleeping too well these days, as many of the folks up here are not. So maybe to segue into the particular issues unique to Western Mass, one of the factors is even though we have Springfield in Hampden County, we have 3 of the 4 most rural counties in the state, with Franklin, Hampshire, and Berkshire. So how are you and your colleagues at the state thinking differently about rural communities, and how what we need to think about differently in terms of solutions, even though, again, recognizing it's early on?
Yeah, so I always like to tell, and Dean, in the short time I've known you, I've probably said this to you, we don't run hospitals from the 10th floor of Ashburton, which is the building I work in Boston. And in the same way, there is, what I mean by that is that the level of expertise and the level of resourcefulness and creativity and innovation that exists among providers in specific parts of the state is going to be the key to unlocking kind of specific local regional solutions. So when we think about our partners and solutions to the challenges confronting us, specifically in Western Massachusetts, I do think differently about Springfield than I do about some of the more rural parts of the state. I know the statistic is 42% for Hampden County. I think it's closer to 70% for Springfield proper in terms of the rate of Medicaid enrollment, which is true of a couple other municipalities in the Commonwealth. But just to say, there is kind of a unique responsibility that I think the state and Mass Health plays in ensuring access to coverage in Springfield. And so I'd say a couple things. One, there are going to be more people without comprehensive health coverage. I think that was very clear in Caitlin's discussion and presentation. And the experience of being uninsured in Massachusetts, generally, a shorthand for it is you get care at a community health center or a hospital. We've kind of designed our system over the last 20 years where if you do not have health insurance, we came up with a way to pay for your care specifically at community health centers and hospitals. And so one really important piece is to say, okay, if someone has Mass Health or someone has health coverage through the connector, and despite all of our efforts, which again we'll talk through, that person may lose coverage, what is the network of providers specifically in this part of the state, and what partnerships do they have with local community organizations that may be more plugged in and engaged with the individual losing coverage to make sure that that person reestablishes a connection of primary care? I'm sitting on stage with the 2 most important, I think, providers in Springfield who have both a really challenging responsibility but also a unique opportunity to kind of put their arms around a population in an underserved geography that is going to experience a unique amount of disruption when it comes to loss of coverage. So how can we support Caring Health and Bay State and other providers in ensuring that someone who needs to kind of redirect to them in order to establish a primary care relationship, get their meds filled, those sorts of things, how are we going to do that together? I also think, typically when we think about then the more rural parts of the state, there are a number of things that we've done over the years that I think we're going to have to double down on. I mean, certainly when we think about the Berkshires, what we see in our own data are particularly high rates of substance use disorder. And we have a program at Mass Health called the Accountable Care Organization Program, where they're kind of regionally focused provider and health plan partnerships that are responsible for the cost and quality of care delivered to a population. And we've been hard at work with Berkshire Health Systems and their health plan partner Fallon for many years now, talking about how you extend beyond the traditional health system and 4 walls of a health center to extend mobile opioid treatment programs into the community to expand access. How do you reach people where they are when there may not be a short bus route that can take someone from their home to a provider? I think when you enter into a time like the one we're heading into with kind of a level of budget pressure that I certainly have not seen since I've been at Mass Health since 2016, the question becomes one of like pretty ruthless prioritization. So what are the programs that we have in place now that are actively connecting people to care, keeping them out of the hospital, keeping them out of the emergency department, and ensuring that they're getting great care at the lowest cost possible? Where there's evidence and where there's a true belief among providers, a lot of this has to be provider-led, like those are things we are going to keep doing. To the degree that there are programs that we have tried over time that don't have the same level of results that speak for themselves, and we may have to take a different route, but it has to be done in really close partnership with the providers locally who understand what works, what doesn't, and how to keep people engaged.
I think, I'm sure I'm not the only one for whom that's music to our ears, Mike, to hear, which is not unusual, that MassHealth really wants to work with the providers, with the advocates, with the people in the different parts of the state who really understand much more about the population served here. And Tanya, I think Mike did a great job of teeing up my question for you, which is, I had about 68% of your patient population being covered by MassHealth, and also that over 51% of them prefer to speak in a language other than English, even compounding the challenges even more. So I would think your staff, your providers, your community health workers, your outreach workers must really feel under tremendous stress these days with the patients that they're trying to provide such high quality care to. So can you tell us a little bit more about what it's like to sit where you sit?
Sure. First, good morning, and thank you for having me, allowing me the opportunity to speak to this very important topic. At Caring Health Center, as you mentioned, there's 68% of our patients who are on MassHealth, and we have maybe a little over 21,000 patients, so that's roughly about 14,000 lives that are on MassHealth. And so we're incredibly concerned, right? Because, I mean, you're speaking about a lot of people who could potentially lose coverage or just be ineligible for the different coverages that are available. And then at the same time, we're also adding to the burden of staff. We're already short-staffed, and then in addition to what's being proposed, then our staff basically are going to be even more burdened with a volume of individuals that will be coming in. Caring Health Center does not just assist their patients, but we also assist the community. We are a health navigator site, and so it's not just Caring Health Center's patients, but it's anyone in the community that enters into our door. We're going to assist. Many of these individuals, of course, are going to be ineligible for Medicaid, and then, of course, when they lose the federal tax credits, that's only going to exacerbate. And then, of course, Dean, of course, will experience individuals coming into, the hospitals, because we know that patients who lose their coverage are going to defer seeking preventative health care, and they're going to end up in the hospital systems, which, of course, is going to, they're going to have more acute healthcare problems, and they're going to present to high-cost health systems, and that's actually just going to make it worse for the state. Caring Health Center, and I'm not just speaking on behalf of Caring Health Center, because we know that there's several community health centers that we partner with or that we're friends and families with. So we're going to continue to provide the care because that's who we are, and we're committed to who we are. As a federally qualified health center, we are obligated to see patients regardless of their ability to pay. So our doors are going to remain open, but this is also going to inevitably put a burden on the uncompensated care pool, right? So many people are going to fall out of care, and they're going to fall into the health safety net or MassHealth Limited, and we know that they're not going to be able to absorb that. So it's really challenging for us right now, and I'm going to talk a little bit about, and Caitlin did such a beautiful job. I feel like some of the things that she spoke about, I feel like I'm reiterating some of what she already said, but so when I speak about like health navigators and assisters, the concern that we have, of course, is implementing the reporting requirements. That's going to be a huge burden, assisting people, especially when they have to comply, and then every 6 months, just think about it, every 6 months, people are going to come in and they're going to have to reapply. We know many people fall out of care because, one, they're transient and they're changing addresses all the time. So when we have to reach out to individuals, we're not always successful. We do our best to try to reach out, but people are moving on the go, people are homeless, and you're not always able to reach them. We had 2% of individuals that were uninsured, and now that's increased to 9% of folks that are uninsured, and that's because during the re-enrollment time, they just didn't get the information, and of course, so they passed that re-enrollment period, and then they fell out of the system. Workforce burnout, again, we have a lot of, and this is not a Caring Health Center, but many health systems are dealing with shortages. You have shortages in nurses, we have shortages in providers, that we're just not as swiftly able to get people in the doors as much as we want to. Caring Health Center has a 2,600 patient wait list. And I mean, if we can just think about that, think about our own lives, when you can get access to the care that you need because a provider is not available, or you just, the appointments, you don't have the appointment slots or the vacancies to get them in. And now, on top of this, you're gonna have people who are probably not even gonna seek care because only unless they end up really ill, really sick, and they end up at the hospital. And so I feel like we're taking a step back. I feel like we're following, the state of Massachusetts has come so far, and I feel like this is only going backwards from what we've achieved in terms of making sure that people had access to insurance and making sure that people had access to care. So community health centers will need to dedicate more resources to staff and assistants, and which is going to be challenging, right? Because you need the financial resources to do that. And we're going to try to continue, of course, to provide as many services that we can. But, and when I say that, for example, like transportation services, we try to provide wraparound services. We don't just try to provide medical care, but we try to remove as many barriers as possible. We try to make sure that if patients don't have a way to get into care, we provide transportation services. We provide mobile units to be able to go out into the community health worker services to make sure that, we're trying to bring people into care. And so now people are actually gonna fall out of care, and people are gonna become sicker. Care is gonna be delayed. I wish I had a magic wand and I can just make it all go away, but unfortunately, we just can't. And so, again, we're going to continue to do what we do at Caring Health Center. And as Caitlin said, I think one of the other concerns for us is that Medicaid reimbursement is 50%, close to 50% of Mass Health Center's revenue. And so that's going to make it even more challenging for us. And we are hoping that the way around this, of course, is working with the commercial carriers to, get them to pay us at least the same rate as Mass Health. Again, because when patients lose their coverage, health centers are still going to be there. We're not going to stop providing care, as I heard somebody say earlier. We're still going to provide the care, but at the same time, we need the resources to do it, and we want to help our partners, help our hospital systems that, patients are not clogging up the ER or backing up the ER when they should be going to their primary care provider for preventative services. The goal is to try to get help our communities become healthier, not sicker. And here's where we are in the reverse of that.
Yeah. Thank you. Dean, we're sort of teeing up this as we go down the row here, but as the largest healthcare organization in Western Mass, I was thinking, and I don't think I could even count up the different ways in which Bay State is going to be affected by these federal actions. Inpatient care, outpatient services, community health centers, teaching, research. You are definitely getting hit from all angles. Can you help us sort of parse this out a little bit? I'm sure you're concerned about all of this, but are there, what are your biggest concerns for Bay State Health and for the significant underserved communities that you provide care to?
Yeah, thank you, Audrey. I appreciate the question, as well as I appreciate everybody being here. I think Caitlin did a really nice job of articulating the actual sort of specifics of things that are going to change. Our internal analysis lines up exactly with what she said in terms of the areas of impact. So what I thought maybe I could add is some color commentary in terms of what it's going to feel like for us as a provider. I feel a little bit like about, 15, 20 years ago, I was in Salt Lake City, Utah. Not a place where tornadoes hit, ever. And in fact, I lived there almost 20 years with my kids and wife, but it was about 15, 20 years ago. And I saw these dark clouds. I was coming out of work, and The clouds were really dark, unusually dark. And as I was watching those clouds, they started to take on a color of almost a deep purple. And I thought to myself, I thought, that looks like a really bad tornado possibly forming. But I thought, that's not going to hit here. We're in Salt Lake City. There's a lot of people here. And it doesn't happen here. So I thought, that's not going to happen. But gradually, as I watched this and I started to drive, it got worse and worse. And of course, history will tell you what actually came was a tornado. It hit downtown Salt Lake. It did a lot of damage right through the city. I feel like that with this OB3. I've been watching this bill since the discussions started and the debates back and forth between the House and the Senate. And being a healthcare policy person, watched very carefully, and as the different provisions were added, I kept thinking, they're not going to do that. That can't possibly be something that they think is going to be a good thing, let alone the consequences. It transforms the landscape of how we provide care. The reimbursement reductions and all the eligibility, we've been through 6-month redeterminations. We know what that's like. We're going to be asked to go back to that from where we've come? I said, no, that can't happen. But then it passed. And now I still am watching these storm clouds, and I think that if people really understood what this means, this room would be full because the impacts are going to be real, and it's going to affect real people's lives. And I mean, people are going to die. It's bad. I do have some optimism that the state will respond and do something to help us. Facilities and systems like us will respond, but our response is going to be limited to reductions in jobs, since 60% of our workforce is 60% of our expenses are workforce. We've probably gonna have to reduce services. Access gets longer. And it's not just Medicaid, it's the commercial insured population. Rates are gonna go up too, because we don't cover all the expenses from Medicare and Medicaid. To the degree that there's shortfalls and increasing shortfalls, the pressure on commercial insurance goes up as well. So it's real, and the impacts are gonna be significant. And I will also just add additional color commentary here. There was the question that I think Mike alluded to that has been talked about. Are we going to work with other states? And there's some opportunity potentially there. It's a great question. I'm relatively new to Massachusetts, been here just over a year. Prior to this was in Colorado, and prior to that, like I said, I was in Utah. While I was in Utah, served in that legislature, which is a very red state. Early in the election, after the election, the presidential election, to the credit of the administration, our administration in Massachusetts, we got calls, and I assume they're calling other health systems saying, do you have relationships with red states that we could possibly partner on a bipartisan basis to perhaps alter some of what's going to occur? And so I thought, well, I've got a lot of relationships in a red state. In fact, one of the senators who's in a red state is a family member, kind of distant. He's a stepbrother of my wife's family. But I was the first person he lobbied for a delegate vote when he ran for office the first time. So deep relationships in a red state. I called them, and I asked them, our state wants to do some bipartisan things together. Would you all be open to some of that? And they laughed at me, and they said that's ridiculous. We have way more influence now, independent from you, than if we try and partner with you. So then I started to have conversations with colleagues out there associated with the policy impacts, because just like we're going to be affected by access, just like we're going to be affected by reimbursement, they are too. One of my good friends, best friends in the world, was the majority leader in this red state, and now he's over the hospital association in that state. And I said to him, what are your hospitals saying? Because they're not different than us necessarily. And he said, that OB3 is going to wipe out their margins. One of the larger, more healthy systems is going to wipe out 2/3 of their margin. He said our other hospitals are going to suffer dramatically. We'll see potentially closures. We don't know how we're going to deal with this. And I said, are you talking to lawmakers about this? And he kind of surprised me, and he said, we had to stop. And I said, what do you mean you had to stop? And he said, they're not listening to us either. It's not a policy argument, it's a politics argument, and it's almost this, I hate to say it, tribal mentality that took over. And so that's when I lost optimism that this bill is going to change or be reformed, let alone the numbers necessary to get there and make it happen. So then it becomes, what are we going to do? What are we in this room going to do, and how are we going to respond? But like I said, it's real, and it's pretty scary.
Thanks. I can't, it's very interesting to hear about those interactions from other states. Hopefully there'll be some more positive ones with some others. But Alana, as I said, we first met many years ago, and I had no idea about programs like Volunteers in Medicine in the Berkshires. And it's fascinating and wonderful. An organization that's dedicated to meet the comprehensive healthcare needs of people in the Berkshires who don't have insurance. And that program is staffed by over 70 volunteer medical professionals. So I think I'm probably not the only one who didn't know much about those kinds of programs. So maybe we could start with you just explaining a little bit about how Volunteers in Medicine works, and then we can, next round, get into some more details.
Sure. So thank you for having me on this panel. I am the alternative to, I think, some of these systems that are sitting here. So Volunteers in Medicine Berkshires was started the idea came around 2003. It was based off of a Harvard School of Public Health project that showed a very high uninsured rate in Berkshire County. It is a tourist economy, lots of independent workers. This was obviously before universal health coverage. And so they saw this big need. Actually, Blue Cross Blue Shield Foundation did a survey later on that showed 20% of people ages 19 to 64 in Berkshire County were without insurance for part of the year as well. So it's based on a national model. It was started in Hilton Head in a similar environment where there were a lot of retired people and a lot of service workers. And it was a motivated person who picked someone up off the side of the road and was bringing him to work, and they started to talk about access to health care. And he said, wait, I think we could figure this out. I have lots of friends around here who are physicians. We could figure out a model. And so they started the first Volunteers in Medicine model in Hilton Head. It is still going. They have over 30,000 patients, and they are a comprehensive health system. So we started in 2004. We are also a comprehensive healthcare program. We have 70 clinical volunteers. We have 160 volunteers, though. So everybody from front desk workers to drivers to interpreters, nurses, and we do comprehensive health care. So behavioral health, dental, primary care. We have cardiology, nephrology, GI, integrative pain management, optometry, ophthalmology. You think about what you need. It is all actually within our buildings. We have 2 buildings, one in Great Barrington and one in Pittsfield. And with these 160 volunteers, we have 20 staff. I think what's really interesting, so we take care of 2,000 people from Berkshire County who are ineligible for health insurance. And what's interesting is we are a real integrated model of healthcare, clinical care, and the community health worker model. And so from the beginning, we understood that our volunteers are going to be transient. And so the most important thing for our population is that care management model. So we operate with full medical care management model that's integrated with community health workers. And so every patient who comes in is actually, the team of medical care managers and community health workers work together to really put that person in the center to really impact health of that individual. We are, at this point, people who are ineligible for health insurance. We know who those people are. But what has happened is we get to be that community-based organization who also gets to be a healthcare center. So we get that trust that you get when you are one-on-one with your healthcare provider in a room, and when you're with those care navigators from the community. And so we're able to see what's happening in the community really, really quickly, and we can be responsive to it, not just within our healthcare model, but by working with other community-based organizations to ensure that the needs of everybody are met.
Great. Wonderful program. Thank you. Okay, we'll do another really quick round and then turn it over to all of you for questions. Mike, one of the things that I know a lot of people in Western Mass have talked about, which I'm less familiar with, is the Rural Health Transformation Fund. So can you tell us a little bit about how the state's thinking about that and the application and all of that?
Of course. So And I don't recall if this was highlighted in Caitlin's presentation, but there was a $50 billion fund set up in OB3 called for rural health transformation, and it was, I think, originally put in there to kind of bring red state senators on board who were hearing from hospital associations about the impact of these cuts. And so this was a way of saying, look, rural hospitals, critical access hospitals, they'll be okay. They're going to kind of get this money. It charged the federal government, the Center for Medicare and Medicaid Services, with putting out an application that every state can fill out. And we got that application a month ago, and we owe it back next Wednesday. So we have been working very hard on putting a great application together. And the way it works, again, $50 billion over 5 years, the idea being across 50 states. What the federal government asked us to do is to say, look, how would you spend a 50th? How would you spend $1 billion over the next 5 years to transform rural health? So a couple things. One, consistent with what I said earlier, this is all about kind of provider and community-led ideas. So we have talked to everyone. We have put out a request for information. We got 130 excellent responses that we have been poring over on a really compressed timeline in order to put our best foot forward. A tenth of the state, 700,000 people, live in geographies that are characterized as rural. And so this is a big opportunity for us. And I think, I know most of this session is focused on things that the federal government is doing that we don't like. It is okay to acknowledge that there are elements of what gets called MAHA that I think everyone in this room agrees with, around kind of expanding access to primary care and chronic disease management, particularly in underserved communities, or healthier food for kids, things like that. And so I think the challenge is, you step back, you think about it, and you say, boy, $1 billion is actually quite a bit to spend in 5 years when you are trying to limit yourself to the constraint of avoiding a funding cliff at the end. We, and when I say we, I mean government generally, has a horrible track record of throwing a ton of money at rural communities and then saying, enjoy, see you later, and leaving a hangover on all of that spending that then just kind of disappears and programs stop and supports go away. So the challenge has been, how do we incorporate all this feedback and put forward ideas that are going to transform rural health and be sustainable, right? So you don't just want to buy $200 million of services every year, because what are you going to do in year 6? And so our group, it's been a terrific partnership with the Governor's Director of Rural Affairs and the Department of Public Health and Mass Health, and again, all of our community partners, to kind of put forward a number of initiatives. I'll highlight 2. And again, our application will be up and out next week, so you can have some bedtime reading when it does. But one opportunity is around building the health information technology infrastructure to get systems out here, specialty care networks, primary care networks, to be kind of fully interoperable and connected, so that no matter kind of who you are and where you get care, there is an easy way to very quickly understand what your needs are and how to kind of triage you to the best care. So think about that as kind of one-time investments that will unlock enormous opportunity for clinical improvement in the years ahead. I think another idea is working with health systems around how to specifically expand primary care. So you can imagine a model of care that looks something like, you've got your primary care providers at a health center or a hospital, and how do you extend them into the community, particularly in remote geographies where remote patient monitoring could be the thing that prevents a hypertensive individual from needing to come in every 6 weeks for a visit. A, that just makes your wait list longer, and B, you can check the person's blood pressure from home. And if something doesn't look right, then rather than, again, trying to figure out transportation to make the 40-minute drive in, we send community paramedicine out. All of this relies a level of investment in infrastructure that for many systems is not currently in place. So how can we use this opportunity to develop that kind of infrastructure and help people, where particularly in parts of the states where chronic disease is higher, sustainably and more easily manage their care at home in the community where they want to be. So it's those sorts of things that we're we're excited about. We are going to put our best foot forward. All signals are that the federal administration is pretty interested in those things too, and we have this unique opportunity to take advantage of it.
Great, really, those are really interesting. Thanks, Tanya. I know it's at Caring Health Center. You're part of C3, which is an ACO, as you were describing earlier, Mike, and then also, of course, with the Mass League of Community Health Centers. And I'm sure both organizations are really focused on all of these, as you said, because these are not issues specific to Caring Health Center, other than maybe the patient mix. But all the health centers are really going to be struggling with this. Are you hearing anything? Or, again, I know it's early, and there's a lot of provisions of the law that we don't even have enough details on yet. But are you hearing much through those groups in terms of how they're thinking about dealing with this?
Yes, how we're strategizing. First, let me just say thank you to Undersecretary and Governor Healy's office. We're working, of course, we'll be looking forward to working with them on ways to lessen the burden for the application process for the 6 months. One of the things that I didn't mention earlier about health centers, I wanted to just give some stats here on the challenges of job losses. When you think about it on a national level, 34,000 community health centers, 34,000 community health job losses, could potentially happen, and then 1,800 community health center site closures across the country. And so, community health centers, and Caitlin said it earlier, we're already, dealing with financial pressures, and so, all of this exacerbates it. But to your question, so as I mentioned earlier, the wait list issues, the access is today. And so we want to strengthen community health centers. We want to strengthen community health centers and community capacity now, so that we're able to be best positioned to deal with the waves that we are facing with individuals coming off of insurance or being underinsured. And obviously we want to thank again the legislature, because we're incredibly grateful for the funding that we recently received. Community health centers did recently receive funds, supplemental budget, and we've been working with the Mass League of Community Health Centers and our community health center colleagues collectively together, ways on smart investment. And so how are we trying to pull resources together? That includes, innovations such as models of care moving forward, ways that we can work together on shared services. So we've been having strategic meetings, coming together, really trying to just look at ways that, we can try to cut costs and share some of the services, share some of the expenses. And then the Mass League has also provided a ton of technical assistance around contingency planning. So we've been trying to do predictive modeling in terms of walking through different scenarios and thinking, how community health centers, the models, looking at the impact of losing federal funds, what can we do in terms of some ideas to help us, fill these gaps, to, really think about, solutions to try to solve for that. And then, we also do want to keep coming back to the state to ask for more funds. We don't want to keep coming back. I said we want to. We do not want to keep coming back to the state to continue to ask for funding. We need safety net providers to be financially sustainable. And the Mass League, in partnership with, again, my community health center colleagues, we developed a legislative agenda with 2 bills in mind to increase the revenue coming into the health centers at no cost to the state, one of which I mentioned earlier. This includes commercial payment floor legislation that would require all commercial plans to pay at least the what Mass Health pays, and again, as I stated earlier, we think this is fair. And one of the other things that we're hoping for the legislators is to help to protect the 340B revenue at community health centers, because, countless of other states have done this. And so I'm pretty sure there's ways that we can try to figure out how to do the same to restore revenue to community health centers that we've relied on for decades, and relying on those sources have allowed us to add additional programs to help our patients. So in terms of access and affordable medication, those are some of the, ways through the 340B discount savings program we've been able to have the transportation to be able to get our patients into care. So it certainly has been helpful. And again, unfortunately, not a replacement or to make providers whole, but we are excited about the Rural Health Transformation Fund. We're not a rural health, but our sisters and brothers are. And so just want to say thank you for allowing that. I would lastly just say this. We would welcome we will welcome those dollars for workforce development. We do know that workforce development and training, since we know access for our patients is directly linked to having a very robust workforce team. And so CMS has already announced that they will no longer be funding workforce initiatives through the 1115 waiver process. So we would love for the state to use some of those funds to help fill some of those gaps there. So, but again, working collectively as a team to try to figure out ways to share services and resources together.
Yep. Again, I think throughout one of the themes throughout this that Caitlin talked about, and Andrew and everyone earlier, as well as others up here. I mean, at least we have this history of collaboration and trust and respect for each other that I think shores us up as well as we can be to work on this together. So just briefly, so I can get to audience questions, Dean, I know when Bay State was already in the middle of a big transformation operationally to try to deal with funding issues, expense issues, and similarly to Tanya's role with the Mass League. I mean, if you're active with the Mass Hospital Association, and so in conversations we've had with lots of different types of providers, where everyone's sort of saying, this isn't tweak around the edges stuff. I mean, the significance of these cuts are going to require some pretty transformational, overused word, but transformational change. So what are, just very briefly, what are some of the things that you're hearing in your network?
Yeah, we have been on a journey for a turnaround, if you will, and it's no secret. I think we've been very public as an organization about that journey. Our organization had been losing quite a bit every month. The numbers are, I'm not sure the numbers are public, I won't say it, but they were losses. They weren't break even. We had to institute a lot of really hard measures associated with trying to right-size the organization, trying to increase some efficiencies, trying to look at our throughput, our staffing, those kinds of things, and have gotten to the point now we turned the corner and have now had 6 months of continuous profitability. Now that profitability, our margins are really used to reinvest into our needs of equipment, beds, expansion, replacing of beds, wheelchairs. It's not like there's a margin that's going into our pockets. We think of the margin in terms of the dollars that allow us to sustain the organization on a long-term basis. But in that context, with the big beautiful bill, it's a little bit like, I like my analogies, or some people do, some people don't, but I lived in the Dominican Republic for 2 years, did some volunteer work down there, and lived in conditions there that are not like in the United States. We didn't have running water all the time. So and you couldn't drink the water. You had to boil it even when you could get it. So I was living in that situation, and my health had deteriorated. I was kind of weak. I was weighing 120 pounds. You can't imagine that. Same height. But in that state, I got bit by a mosquito, and the mosquito gave me dengue fever. If you're familiar with dengue fever, it can be fatal. But for my condition, it was much worse. And I didn't have access to a hospital or healthcare, so I just literally laid in my bed and was at one point, in the middle of the night, I thought to myself, okay, this is it. I'm going to die. And I just accepted my fate. Fortunately, somehow, my body, recovered. My point is, the OB3 is hitting us in a time when we're not necessarily really vibrant and healthy. We already are facing a lot of challenges and have faced a lot of cost pressures and challenges, I think, have been articulated by Undersecretary Levine and others associated with our input costs are high, our staff costs are high, our electronic medical records are through the roof in terms of the cost for those kinds of things. And that is an environment in which we're going to be expected to absorb OB3. So it won't be easy again, but I don't know, like I came through with my dengue fever. Somehow we'll figure out a way.
We're glad you came through. So lastly, before I turn it over to the panel, just like we repeatedly say, the state cannot make up, all of these funding gaps. It's just not possible. And I think I could venture to say that programs like Volunteers in Medicine can't make up the gaps in the delivery system. But I'm sure, in fact, I know, but I guessed already, Alana, that you're getting a lot of calls from organizations or parts of the state who want to know, or parts of the country who want to know more about what role organizations like Volunteers in Medicine might play. So what are your thoughts about where in this tsunami of crises Volunteers in Medicine can play a role?
Yeah, so I'm going to talk a bit about kind of some solution-based thinking around all of this. You know, I do think that one of the things that will come out of this is that we will have to disrupt the system a bit. And I think we need to start to disrupt the system. You know, FQHCs, hospital systems cannot fail, so this is an and. But like what we've been hearing, you know, the insurance company, you know, the cost of everything is skyrocketing. And there has not been a huge amount of discussion within our state about alternative models that aren't within the existing system. So I think right now is the time to start to pay attention to what do we have in the state that already exists that can be used as models or examples of ways to work alongside the existing larger systems like FQHCs and hospital systems to try to decrease the harm. So we can't prevent it, but this is a harm reduction, these are harm reduction strategies. Volunteer model healthcare systems in Massachusetts is a no-brainer. We have so many healthcare providers, we have so many volunteer healthcare providers, and we have lots of people who were professionals in all different things who now can go into their encore career. And the encore career, we know, is basically people's most productive times in their lives. You've taken away the stressors of raising a family, of having to make money, and people are extremely productive from 65 to 90, you know, or 70 to 90, or, you know, that is a lot of years of service that is still there. So I think really really figuring out right now how to use models like Vim Berkshire's to help assist other areas of how do you create a similar model to start to offset the impacts so that when the wait list for healthcare is, like in Berkshire County, over a year to get a primary care provider, or, you know, what is the financial strain that the FQHCs can actually take for uninsured clients? What are the cuts that they would have to make? How can there be collaboration between these models and use a resource we have? I think the second thing is the community health worker model. The state has been talking about community health workers. Jessica, you know, introduced me to, you know, that Robert Wood Johnson chart that we all know. 80% of what is going to, you know, someone's health outcomes are not clinical. And the idea that a community health worker has a panel of 10,000 patients or 5,000 patients, it doesn't make any sense. And so using community health workers, you can have 4 community health workers making a very good livable wage at the cost of 1 provider, and really investing in their role right now to actually be integrated into the care system fully, so that they can actually do that care management. They can actually be working both clinically, both social determinants of health. They can be the link. They are the trusted source. People from the community are the trusted source for people who are in the community that they're working in. I think innovative models, so getting out of what's reimbursable and thinking about other ways in which we're approaching health. So we were talking about behavioral health before I entered in. Not everyone needs a therapist, right? People need socialization. So the impact of, you know, how do we create socialization for clients? So at VIM, we do hiking Saturdays with breakfast. We do dinners. We do, you know, we do a parenting, you know, get together and, you know, have an education thing on how to sign up for camps. But that, you know, for most of our clients, thinking about how do you create socialization, those are going to impact healthcare. Thinking about legal and those social determinants of health and how we're investing. And then finally, really thinking about how do we actually come to the table as a healthcare organizations and community-based organizations who don't talk the healthcare model lingo and all of the acronyms. I'm a nurse practitioner, so I'm lucky because I get to see patients and I get to do this other stuff. But linking community-based organizations who are not in healthcare with healthcare organizations requires a strategy and a really unique facilitation process. So using models that already exist in the community to actually have conversations at the table with these different entities to really talk about solutions and trust and that. So finally, really quickly, because I know we're, so just a quick thing, because I think this is important, because I've heard it from DPH. Volunteer, our budget is $2.6 million. That's 20 staff, that's 160 volunteers, and we have 2,000 patients. So that's a return on, that's about $1,300 per person per year to get full health care, dental, behavioral health, primary care. We have all of these specialists actually from Springfield who come out to the Berkshires to do care. The lab work that they get is equivalent, if you get Medicaid reimbursement, is about $175 a year. Our avoided ER costs, if you look at our demographics, is about $1.4 million a year, right? So that's just avoided ER, and that's probably under, that's if we say a hospital, an ER visit's $1,000, that's, $1,000 reimbursement. So thinking about these models, they do work. Even we do not get any health insurance reimbursement. It is privately funded. We are privately funded through foundations and individuals, but that investment and that return on investment for the state is a huge thing to start to think about to fill those gaps. So really quick things: supporting technical supporting people to get started. There are lots of people who are calling us, especially in the Boston area, who are already getting things together. Really defining what is the role. So how do we manage people who have a lapse in coverage? What's the role of the free volunteer-based organization versus the FQHC? How are they working together to make sure that there's no lapse in time, that people are getting care? Thinking about volunteer provider licenses should be free and easy to get, and lots of states have actual malpractice in legislation so that it's easy to get started with volunteer providers and healthcare centers that are volunteer-based, free, that already have malpractice, and the volunteers can quickly keep their license going so that they don't have a lapse in that. So that's just some quick things, and yeah, thank you.
That is fantastic. Thank you so much. Thank you all. It's really a privilege to have you on this panel. So let's turn it over to all of you. Mike, I think we have some microphones coming around for anybody who has questions, comments, thoughts about dealing with all this. Okay, we got one over there. Yep. If you could say your name and where you're from.
Oh, sure. Good morning. My name is Marsha Morris. I'm a commissioner for the Reparations Commission for the city of Northampton. I have a question and a comment. I was really interested in Ileana. Is it Ileana?
Ilana,
Yeah.
that's okay.
Your comments. I mean, I think we got it after the first presentations. This is bad news from some perspective, but I liked where Ileana was coming from as a community person. I was sitting here itching to say, well, okay, so the system was already broken. I got an email from Valley Medical 2 weeks ago that they can't even deliver care anymore at the same standard because they don't have enough staff people. So this was coming anyhow because the costs are astronomical. So it seems to me like Ileana's on the right track. Two things have to happen, or maybe three things. One, challenge the legislation, of course. Two, it seems to me like there needs to be a way to cap costs. So Mark Cuban is doing this fantastic pharmacy thing of trying to bring in pharmacy goods at cost. Why doesn't the state of Massachusetts partner with someone like that to help bring down the cost of pharmaceuticals first and foremost? That would help. I agree with Ileana around come up with a different model. The system's going to break anyway, so go ahead and start it and start trying something new. It seems to me like we spent the whole morning talking about reacting to a system that doesn't work anyway. So why not go ahead and start to think outside of the box, like with community workers? I don't know if that's the answer, who knows, but it sounds to me like we're in new territory. This could be a good thing, not a bad thing. Maybe medical care shouldn't be a place where people think they go into to make so much money. Maybe it should be about health care. So maybe that is the first and foremost model to break. It seems to me as though you're trying to put a Band-Aid, wrap some tape around a couple popsicle sticks, and keep this thing together when it's falling apart. So why not just go ahead and smash it? I think you're right on the money there. So that just was a comment. And my question was, what new innovative things are you thinking about besides what this lady was talking about?
Sure, I can start. And I think the enthusiasm for a lower cost, higher quality way to deliver care is right on, and one that everyone has a strong interest in. And I also learned a lot about Vim Berkshires and want to learn a lot more. So so this has been really productive. I guess I would layer on a piece around technology. I mean, it is 2025. There's already a large system in the eastern part of the state that has started using more personalized AI type approaches to deliver some version of primary care to people who can't access a primary care provider in the moment. That also has its own challenges, but we have to try everything, to your point. So to the degree that you are someone who is waiting for a primary care visit or a derm visit, or a number of things that can be handled via telehealth, to at least just get triaged to the right place, so you're not waiting for 6 months. I think we need to be really open-minded about both community health worker type models and also more technology-based things that are only going to get better with time. The only other thing I'll say is that at Mass Health, at least, look, on the pharmacy side, yes, drug costs are killing us. Our per member spend on pharmacy grew 18% last year, right? There's no way, like, that just can't continue. At the same time, we scraped $550 million back from drug manufacturers last year in the form of additional rebates that we negotiated with them. And so maybe I'm just reinforcing your point. There's a lot of good stuff we're already doing, and it is still on a trajectory that isn't going to work under the current model. So I think we need to be open to all ideas. And then just the last thing I'd say is, we do have this ACO model. We do pay differently and I think better for primary care than most other payers with our kind of monthly payments it's more money and it's reliable, predictable revenue for primary care docs. What I often hear from providers is, I would love it if other people paid the way Mass Health did. Particularly around primary care. And I think part of the problem is even if Blue Cross wants to do something innovative, or Medicare does something, or Mass Health does something, you're still stuck as a provider saying, like, all right, great, just another thing to manage, right? So we're like going to get paid one way over here for my Medicaid folks, I'm going to get paid a different way over here for Medicare, a different way over here for commercial. The complexity, the ability to manage it is just adding layers. And so there's been an effort, but I think we need to do a lot more to just align payers. People need to just start. It doesn't matter if you're commercial, Medicaid, Medicare. We need to figure out a way to all do things together. Otherwise, you're asking providers to have feet in multiple canoes. It's just a hard way to stay upright.
Audrey.
Yep.
I was just going to comment. I think the sentiment there is good, and it reminds me, I'm not sure I'm going to get who said this right. I think it was Rahm Emanuel that said, never let a good crisis go to waste. Clearly, we're going to have a burning platform here to do some significant change. And I do think the ideal, there are some pretty significant reforms that could occur that if there was an opportunity now, the opportunity may present itself. And to the credit of the Undersecretary here, Levine, we've been talking about really significant reforms that could potentially change these. The challenge, of course, and the pragmatic reality is healthcare has earned the reputation and deserves the reputation of being the graveyard of innovation. We have, and part of the reason is because there's so many disparate entities that are a part of the healthcare system, and as well as our payer dynamics, our incentives, the emotional purchasing of how people approach healthcare. Our culture in the United States is such that it's very difficult to make those big landmark reforms. That's not to say we're not going to try and we're not going to look at those. We will, and perhaps we can come up with some ways to do things better. It is an opportunity if we can embrace it collectively.
Absolutely. Other questions? Yeah.
Hi. Not a question, but a statement. I want to thank Ilana for being the first person to bring up social determinants of health. So I represent Aging Service Access Points, and we fall under Health and Human Services, so Mike knows us very well. We are a group of folks who have tremendous experience over 50 years in social drivers of health. And now is the time to be engaging with folks like us and other CBOs. And I have to tell you, we are an investment. I realize that we are an extensive line item in your budget, and there are a lot of challenges at the state level right now. I want to completely acknowledge that. But the work we do is an investment, and we give back more than we take. And I would really look at systems to start thinking about ways in which they can partner with CBOs like us. So thank you.
That's great. Thank you very much. Yep, got another one back there? Oh, okay, come back to that one.
Yes, I'm good? Okay. Hi, my name is Zofia. I work at Jewish Family Services of Western Massachusetts, which is a refugee resettlement org. So what I learned today is that the most impacted people are going to be my clients. And I think I have a few questions. The first is that I'm not hearing anything about refugee medical assistance, and I just don't know how it's being impacted. I know that we hadn't really used it because of Mass Health and how far-reaching it is, and now I'm just wondering if that's going to come back into play for immigrants and refugees in Massachusetts. And then I also wanted just to share and ask, I think that during these times what is highlighted is like the lack of conversations happening between organizations that are on the ground and kind of your bigger organizations, right? Mass Health in particular. And I'm wondering what kind of supports Mass Health in particular and Bay State are hoping to provide for community organizations like ours in order to like be in the weeds with us and hear our feedback, and also offer us a place to share like what is and what is not working, because that has kind of not been happening since I started at JFS 3 years ago.
Great. Well, thanks for the comment and for the work you do. To your second question, we do convene a regular group of immigration providers and groups together with the Office of Refugee and Immigrants, and it sounds like you should join that group. So we'll follow up to make sure that that you're involved in those regular meetings, because I think one of the things we have tried really hard over the last couple of years, and we really kind of kicked this into high gear when we redetermined our entire caseload back in 2023, is regular, routine, repeatable touch points with on-the-ground providers and stakeholders. And to the degree that a huge focus is going to be how we support non-citizens who are here legally through this very disruptive time, we're really doubling down on that with the Office of Refugee and Immigrants and all of our partners. So I think that'll be important. And you asked a great question about refugee medical assistance. It is not something we've relied on historically. I think facts on the ground are changing, so that is kind of one of the topics I think we need to work through together. I certainly don't have an answer here today.
Great.
Sorry. Okay.
Yep.
Thank you all for your time. My name is Rama. I'm a student at Amherst College, and I'm writing a thesis in anthropology this year. But I was just mainly curious about sort of the infrastructure that is being built outside of the healthcare system to accommodate these changes that are happening. So as was mentioned towards the end of the panelists speaking, is the idea that social determinants of health have a very significant outcome or very significant impact on the outcomes that people have in health. And so if you are having these cuts that are happening with Medicaid, health insurance, and just overall across the system, what things is the state currently doing or preparing to do in order to address more of the community welfare or community well-being, like things like affordable housing, things like more access to affordable groceries, things like that, that also influence health in the long term if preventative medicine becomes to be very expensive during these times?
Yeah, I'll start. That's a great question, and Mass Health, and I think Massachusetts in general, has been a leader on addressing social determinants of health for decades now, and in particular over the past 5 to 10 years. So just as one example, in 2020 we launched a program that provided nutrition supports and housing services to some of our most complex individuals who are on Mass Health. And we just published a paper in Health Affairs that showed that participants in the nutrition services program saw lower rates of hospitalization by 23%, lower rates of emergency department utilization by 13%, and if you stayed in the program for 90 days or more, you spent $2,500 fewer per year on healthcare. So the stuff works, which is nice, because we don't just like it, there's actually some data to back it up, so that's good. We are going to continue to invest in things that keep people out of the highest cost sites of care. Dean does not want someone in his emergency department because that's the only place someone can get a hot meal. And so those sorts of things that have evidence behind them, and I'll continue to emphasize that because I think where we're going to have our most difficult conversations, both with friends in the older adult space, but frankly, kind of across the entire continuum, is making sure that we are putting the data front and center to ensure that we are not doing something because we've always done it, but we're doing it because it works and it keeps people in the community, out of nursing homes and out of the hospital where they don't want to be. And just recognize that as a Medicaid agency, to the degree that we are looking at some really difficult challenges, you kind of have to, there is some stuff that you just have to cover. You got to pay for hospital services. You got to pay for primary care. You got to pay for kids to, be able to get their meds filled. Those are absolutely, there's no question there. When you're a state like Massachusetts, which has progressively led the country around food, housing, all sorts of kind of social determinants of health, there is more there that we do that is optional, which I think raises the bar to prove that it is in fact yielding dividends and generating savings and good outcomes for the people that we serve. So I think we'll continue to do that. I think the governor and the lieutenant governor have led really hard on affordable housing. The Homes Act last year puts, I think, I forget how many billions of dollars into developing affordable housing. That has to happen in the Commonwealth. But I think it all comes back to how do we stretch our dollar as far as we can, and where's there evidence to support using that dollar on things that Medicaid had no business doing 10, 20 years ago.
Just one quick thing on social determinants, which I think is super important because there's also students here. Having a resource isn't effective unless there's scaffolding associated with it. So, one of the ways in which we can start to think about how to set up the systems is to think about it in terms of this concept of scaffolding. What is needed? What is needed for someone to actually access what is available? And so, you think about getting up on scaffolding, right? You need to have the trust first. And then once you get to that, how do you create the trust? Who are the community people? Who are the CBOs who have the trust? How are they setting that up? And then you have the resources, right? So if you are a family member and you need to sign up your kid for school, have you ever tried to get into that system as somebody who, what are the things that need to be in place to get into the system to sign someone up for school, or for your kid to play a sport after school so you can work, or to get to the food pantry? What is the process, and what are the questions that everyone is asking to ensure that access is scaffolded? And if we start to ask ourselves reflective questions around this, from health centers to community-based organizations to individuals, and we start to think, okay, what are those little interventions that can be put into place in our own communities to make things more accessible, then the money that gets put into it by the state is going to be put to better use because people will be able to access it. Food pantries are a great example, right? Community health workers at food pantries, right? They can be on the line. People are waiting 2 hours to get food. So what is the role of a community health worker at the food pantry? But then when you're at a community-based organization, if they're going to refer someone to a food pantry, what are the hours? Who's there? What are the criteria? What are they going to have to do when they get there? What information are they going to have to give? Can they get there? If they can't get there, is there a delivery system? Who is the point person for that delivery system? Who's going to make that phone call? Are they going to WhatsApp them back, or are they going to try to call them and they're not going to answer? All of those questions have to be thought about to actually utilize the resources that that money can go into from either the state or other foundations.
I would also add that as part of the Accountable Care Organization that was mentioned earlier, the ACO, so those are definitely some, we look at social drivers, right? We look at ways that, how can we work with landlords, you know, to be able to improve some of the housing conditions when people are dealing with asthma, providing wellness services. At Caring Health Center, we have a wellness where people can come and they can exercise and they can work out, and demonstration kitchen, being able to help individuals just learn healthy eating habits, and transportation. Again, I mentioned that earlier, and this is not a reimbursable service. This is a service that Caring Health Center provides to individuals who have transportation barriers, making sure that we are reaching out to our patients to make sure that they are able to get in. And then one of the most recent pilots that we did with Community Care Cooperative is going into the homes, you know, trying to be able to bring care into the homes for those who are not mobile, those individuals who cannot, you know, come out to get their care out. So I think social drivers is definitely a priority, and it is definitely something that I believe that, you know, we definitely are focusing on, because of course we realize that that is a main driver of some of the health conditions that, you know, people are dealing with today.
Once again, I guess I want to start by thanking all of you for coming and for your commitment to these issues, to your collaboration with each other and with the organizations represented up here. We really appreciate you coming and participating today. And then once again, I want to thank this fantastic panel for all their creative thinking and all the work they're going to continue to do to maybe break and rebuild the system that we need to change.